Hey class, welcome back to week 3. I hope you had a good week 2. And just as a heads up, I did change the settings on the homework assignment in McGraw-Hill, so you aren't limited to timing when you're working on your homework assignment. And also, if you leave it for any reason and then come back to it, it should save your answers. So if that's not what happens, please reach out to me and let me know. If I don't hear back from anybody, then I assume everything is going good. So this week we're jumping into the obstetrics section for chapter 35. The goal for week 3 is to learn what makes OB coding different from medical surgical. You're going to learn about OB, you're going to learn how to build a code character by character, but you're also going to be looking for OB specific details in the documentation. First, you're going to learn how to recognize the key details that drive obstetrics PCS codes. Things like what was performed, when it was performed in the course of labor delivery, and what the documentation is actually describing. Next, you're going to interpret the procedure to choose the correct obstetrics route operation. This is still the what was the objective question. This is what we've talked about in the previous lectures as far as objectives are concerned. And yet this is specific to the OB chapter. Then you're going to apply your anatomy to select the correct body part for obstetrics coding. You're going to focus on identifying the structure involved based on the note and matching it to the body part options available in the OB tables. Finally, you're going to determine the approach that's used for the OB procedure by using documentation clue. And, we're thinking about open versus percutaneous, endoscopic versus any natural opening, etc. The bottom line is learning about the OB documentation, learning how to read the OB documentation through the lenses of a PCS mindset, so you can accurately select root operations, body parts, approaches every single time. You're going to learn how to identify when a device is reported in obstetrics. The rule stays the same. We learned about the devices in the previous chapters, and that is we only code a device if it remains in the patient after the procedure is over. So we're looking for things left in place at the end of the case, not temporary instruments used during the procedure, not drains, not we're not looking at that. You'll also learn how to select the correct qualifier for an obstetrics code. The qualifier is always required as a 7th character, and OB coding it often captures an important detail that completes the meaning of the procedure. That means you'll need to check both the table and the documentation for the specific detail the qualifier is asking for. Finally, you're going to pull everything together and build a complete 7-character obstetrics code. Now, just like we discussed in the first 2 weeks of class, we're still looking at 7 codes. Nothing has changed in that regard. So we're looking for 7-character codes, and this is related to the obstetrics. The goal is to accurately and consistently confirm the section and body system, select the correct root operation, body part, approach, device, if that's applicable, and the qualifier. Then you're going to verify that your final code is supported by the documentation and matches those options that you have in those tables. So here, come back here. Okay, so here are some key terms for you. Abortifacient is a medication or a substance that's used to induce an abortion by ending a pregnancy. In the documentation, you may see a specific drug or phrase like medical termination or pharmacologic abortion. Your coding focus is still on the procedure that was performed and the details that drive the PCS code. Laminaria is a type of cervical dilator which is often made from dried seaweed. used to dilate the cervix. It absorbs moisture and expands gradually. You may see it used prior to certain OB procedures, and it can matter because it reflects cervical dilation. And that may be associated with a device left in place temporarily. Products of conception are the tissue and the contents associated with the pregnancy. So the products of conception for our coding purposes and in order to identify a specific ICD-10 PCS code is you're looking at the fetus, you're looking at the placenta, the membranes, and any related tissue to the pregnancy. This phrase appears frequently in OB documentation and helps us justify what is being removed, extracted, or managed during the procedure. Now, just like with medical surgical, you'll always start by confirming the section first. Character 1 tells you which section of PCS you're coding in, and for this chapter, we're working in the obstetric section. Once the section is correct, then we go to character 2. Character 2 narrows you to the correct body system. And in obstetrics, we're looking at obviously the female genitalia. When we're talking about characters 1 and 2, we're looking at it as the address. You're finding your address in PCS. If you choose up with the wrong address, which means in this case the wrong section or the body system, you'll end up in the wrong tables. So we always want to confirm these two characters before we decide root operation, body part, or approach. In PCS, the first character tells you the section. 1 is for the obstetric section. The first character is always 1. So any PCS code for an obstetrics procedure will start with 1. Use this as a quick reference checkpoint. If you're coding an OB procedure and the code does not start with 1, you're in the wrong section, you're on the wrong street. So you need to back up and see where you're going. Character 2 is the body system, and that is consistent. All obstetric PCS codes use 0 in the second character position to represent pregnancy as the body system. So your quick OB checkpoint is 1, the obstetric section, 2, pregnancy body system, and the code begins with a 1, 0. Now with character 3 answers the most important question in PCS. What was the objective of the procedure? In obstetrics, you'll still apply that same thinking, but the root operation choices are focused on the pregnancy, on the delivery, and the procedures involved with the products of conception. Now, on this slide, we have various root operations. And these are root operations you may select for character 3. Remember, a root operation is based on the objective of the procedure, what the procedure is intended to accomplish. Here are the quick PCS meanings, reminders to help you connect the term to the documentation. Abortion is ending the pregnancy and removing, expelling the products of conception. Delivery is assisting the passage of the products of conception from the genital tract. Extraction is pulling or stripping out all or a portion of the products of conception. Drainage is taking out fluids, gases. You want to watch for amniotic fluid drainage or any related procedures. Insertion is putting in a non-biological device. Removal, taking out a device from a prior procedure. Inspection is visually or manually examining or assessing without taking out or fixing. Repair is to restore to normal structure, function, used when no more specific root operations apply. Reposition is moving a body part or products of conception to a new location or normal location. Resection, removing all of a body part, which is really less common in OB, but is included in the root operation list. Then we have change, taking out a device and putting in similar devices without cutting or puncture. Transplantation is putting in a living body part from another source, and So those are some of the root operations that you have to be familiar with. Again, you ask yourself, what was the intended outcome and how was it accomplished per the operative note? So these are some important guidelines. This is your compass, if you will, with PCS coding. We've talked about the importance of following coding guidelines. With this one, we're looking at C2, which is procedures following delivery or abortion. The idea here is that once a delivery or abortion occurs, there may be additional procedures performed afterwards, such as treatment of complications, management of routine products, repair, or other interventions. C2 tells you how to code these follow-up services and whether they are coded as separate procedures based on what was actually done and documented. Your takeaway for coding practice: do not assume everything is part of the delivery. Read the note, identify whether there was a distinct reportable procedure after the delivery or abortion, and then you want to apply that guideline to decide if there's an additional PCS code that may be needed. Now we're moving into character 4. Character 4 is asking what body part's being treated. With obstetrics, that often means you're identifying the specific structure involved with a pregnancy-related procedure based on what the documentation describes. Your coding habit here is to be very literal and specific. You want to identify the exact anatomical site involved in the procedure, match it to the body part options in the OB tables, and if the note is more specific than the table choices, you want to select the body part value that includes that documented site. So here we have the products of conception, character 0, and the character 1 would be retained, and character 2 would be the ectopic. So products of conception includes the zygote, the embryo or fetus, plus any related structures like the amnion, umbilical cord, and placenta. In obstetrics coding, many procedures are coded to the products of conception because that's what's being delivered, extracted, or removed. For character 4, the body part in the OB tables, you will commonly see the procedures with products of conception, the retained, as well as ectopic, which is what we discussed in the previous slide. Now we're moving into character 5, the approaches with obstetrics. Now, with the approach, the question that we want to ask is, how did the provider reach the site to perform the procedure? The approach is based on the access and the technique, incision versus puncture, scope versus no scope, and whether the procedure was performed through the natural opening. In obstetrics, the approach selection becomes much easier because you're going to train yourself to look for a few clues in the documentation. Cesarean delivery and other abdominal procedures typically indicate an open approach. Procedures performed through the cervix and vagina are often via natural opening with or without endoscopic assistance. If you see catheter needle access without a scope, you want to think of percutaneous. If a scope is documented, think endoscopic. As always, you're going to choose the approach based on what is documented and then confirm your choice for character 5 in the PCS table. So going through the terminology for approaches, again, this is what we're learning with PCS, and you'll see that there is a pattern here regardless of body system. When we talk about open, we're talking specifically about an incision that is made to directly expose the site, which is commonly seen with the C-section. With percutaneous, it would be entry by a puncture or a small incision through the skin, usually needle or catheter. There's no scope used. A percutaneous endoscopic is entry through the skin with a scope. Via natural or artificial opening is entry through the vagina and the cervix, the natural opening via natural or artificial opening. Endoscopic is entry through an artificial opening with an endoscope. External is performed on an external site with no entry into the body. Um, I want you to get in the habit of deciding approach by identifying if this was an incision versus puncture versus natural opening, scope, no scope, and then you can go to the table. Now for OB, it's pretty, you know, it's either via natural opening or cesarean, open. Those are the most common approaches that we will see with PCS within the fetal maternal moms and babies section. Now we're going to move to character 6. Now remember, character 6 is, did you want to ask yourself, was anything left in place in the patient after the procedure was completed? If you say yes, you report the device value that best describes what stayed in place. Character 6 is usually Z, which is no device. The same rule as medical surgical. You're not going to code any temporary instruments that are left in place. Only code a device when it's left in the body at the end of the procedure, and always confirm the device options listed in the OB table that you're reviewing. So for device, we're thinking about one of three things. A monitoring electrode, which is used when a fetal monitoring electrode is placed and remains. That would be 3, character 3. Then we're looking at character Y, other device, which is used when a device is present but does not match more specific options. No device is character Z, which is most common. Nothing remains in place. Always confirm who the device is for in the documentation, and then choose the most specific device value that's left, listed rather, in the table. And now we're going to move into the last character, character 7, and this completes the meaning of the obstetrics procedure. It's always required, just like all of the other body systems, like the other codes. We're looking at that 7th character. Everything that is done in an inpatient setting in the PCS section always has 7 characters. Remember that. Even when there's no detail report, many OB tables will use Z, which is no qualifier, but you always have to confirm that. You always have to double check, because there may be that slim chance that there is a specific qualifier based on documentation. You want to treat character 7 as a required checkpoint. Look at the table first, then confirm the qualifier detail in the note before you finalize the code, before you say, yes, I am done with this one. Double check, and once you can check that off on your list, then you're golden. So, some of the qualifiers that we see that are common with delivery assistance, terms you may see with OB documentation. Hold on one sec. Get some water. These are delivery assistants, and these details matter because they describe how the delivery was accomplished. They can drive the qualifier and sometimes the root operation. So when we look at low forceps, forceps are used at the very end of the delivery when the baby's head is just visible at the perineum. Think with low forceps, the baby's almost out. Mid forceps are used before the head has moved down into the lowest part of the birth canal. Think still higher in the canal. High forceps, that's very rare. And this would be when forceps are used before engagement, meaning the head is not yet well into the pelvis, into the vaginal canal, the birth canal. Vacuum is a suction cup connected to the vacuum pump, and that's placed on the baby's head to assist delivery through the birth canal. Internal vision, manual turning of the fetus by the physician's hand and 4 fingers through a dilated cervix to change the fetal position. When you see forceps, vacuum, or internal version in the note, flag it as a detail that might drive the code. Then, you're going to check in the PCS table for whether that assistance method is captured in the qualifier options. So these terms describe the types of cesarean section incisions that you may see in documentation. A classical is a vertical uterine incision, and just a minute. My dog is playing with his little ball, and it got under his little bed, and he was digging at it, so had to get that out so he would stop digging and distracting me from presentation. So I digressed. So we have classical, a vertical uterine incision. Documentation may describe a midline vertical incision pattern. This is less common today, but still is used in certain clinical situations. Then we have the low cervical, low transverse. A transverse incision just above the pubic line is often called the bikini cut. This is the most common C-section approach that we see today. Then we have extraperitoneal. Access is made without entering the peritoneal cavity. The incision is made into the lower anterior uterus using an extraperineal route. This is less common and will typically be specifically documented. So again, when you see these terms in the op note, treat them as a qualifier level detail, then check the OB table qualifier column to see whether the C-section is captured in the code. So for character 7 for qualifier, we're also looking at amniocentesis. This could pertain to the amniocentesis or other OB drainage procedures. In this case, the qualifier tells you exactly what fluid was drained, so you cannot default to Z. You must check the documentation and match the fluid type to the correct qualifier. So we have character 9, fetal blood, character A, fetal cerebrospinal fluid, and then so forth and so on. So a question that you want to ask yourself is, was fluid drained, and was it diagnostic or was it therapeutic? These definitions are common OP procedure terms you're also going to see in documentation. So some of the abortive procedures we see are vacuum or suction curettage. The provider uses aspiration with a cannula inserted into the uterus to remove the products of conception. Documentation may say suction D&C, vacuum, aspiration, or suction curettage. Your coding focus is the objective, what was removed, what was extracted, and the approach. Laminaria is a small dehydrated kelp rod, which we discussed a few moments ago, placed in the cervix to help dilate. And then abortifacient is a pharmacological agent that's used to help induce expulsion of the products of conception. So here are qualifiers for in utero procedures. When the root operation is repair or transplantation and the procedure is performed on the fetus in utero, the qualifier character 7 is used to specify which fetal body system was repaired or transplanted. So in these situations, character 7 is not the extra information, it's the detail that completes the picture. It completes the code by identifying the fetal body system involved. The table will give you qualifier choices such as nervous system, cardiovascular, eye, ear, nose, skin, musculoskeletal, etc. Which, when you stop and think about it, this is wild. This is surgical procedure. This is a procedure that is done in utero on the fetus, before birth. So it's like a procedure amongst a procedure. It's science is absolutely amazing that an in utero procedure can actually be done, and that we have that highest level of specificity with nervous system, cardiovascular, skin, urinary, etc. So we have reached the end. So all ICD-10 PCS obstetric section codes describe services performed on a pregnant inpatient, but the procedure is reported with the understanding that the patient for the procedure is a product of conception, the fetus, the related structures within the pregnant person. This matters because it changes how you interpret the documentation. You'll often be coding procedures that are performed through the mother, but the procedure's objective is directed toward the products of conception. Details like devices, which would be fetal monitoring or electrodes, and certain qualifiers are selected based on what applies to the fetus products of conception. So, with that, we have reached the end of lecture. If you have any questions, please reach out to me. Please schedule time with me for on Wednesdays from 4 to 5 for office hours. I'm here for you, and I hope you have a phenomenal week. Stay warm out there. So let me stop the slideshow, and we're going to stop the recording. Bye-bye.